Over the past decade in melanoma, we've made significant advances both in immune therapy and targeted therapy. What that means is that we've identified a number of different drivers in the DNA of these tumors that are telling these tumors to continue to grow and to continue to ignore the normal cellular signals to stop growing, stop dividing, and spreading throughout the body. One of the most important drivers that's been identified in melanoma is BRAF. Studies have shown that about 40 to 50% of melanomas, stage 3, stage 4, have a specific activating mutation in BRAF. BRAF V600E and K are the most common. This was the initial driver for melanoma. It's also been identified in a number of other tumors. But this has also kind of opened our eyes to identifying some of these specific molecular events in melanoma and trying to target those with treatments. BRAF has been important for identifying patients that have that driver and then trying to pair that up with treatment opportunities for patients. So when should patients have molecular profiling performed? Well, BRAF testing is considered standard of care. So for any patient that's been diagnosed with a stage 3 melanoma, these patients should have BRAF testing performed. This is part of the standard of care because both immune therapy and targeted therapy are both FDA approved for the stage 3 setting. So patients have the opportunity for adjuvant therapy with immune therapy, whether that is pembrolizumab or nivolumab, or if patients have a V600 mutation in BRAF, these patients can also undergo adjuvant therapy with dabrafenib, trametinib. Now, BRAF testing for stage 3, at this time, we don't have information that helps us know, does this change the prognosis for these patients? And it's not part of the staging based on the information we have. This just opens up different treatment opportunities. For patients who have stage 4 melanoma, not only should BRAF testing be performed, but this is really an opportunity to do more extensive molecular profiling. So for any patient with a stage 4 melanoma, I recommend doing one of the large multi-gene panels because this gives us information not only for BRAF, but other drivers of cutaneous melanoma, whether this is NRAS, KIT, and another important one is Entrec Fusions. So going through these different opportunities, so BRAF, we know similar to stage 3, when we identify a BRAF mutation, this in the stage 4 setting also opens up targeted therapy opportunities. So we have BRAF and MEK inhibitors that patients can use. And then this also opened up opportunities for other clinical trials, looking at kind of next generation BRAF inhibitors or other strategies to try to target this active pathway telling these cancer cells to grow. NRAS mutation is also another defined subset of patients with melanoma, and there's a number of different clinical trials trying to determine how best to target NRAS. Other mutations that may show up on panel testing that have different treatment opportunities that we see KIT. Now there's no FDA approved treatments, but there's been a number of different clinical trials demonstrating different oral therapies that may be beneficial for certain KIT mutations. BRCA mutations. So there can be a correlation both with breast cancer, other tumors, and melanoma that can show up on molecular profiling. But this can be helpful because not only can we sometimes identify a BRCA mutation that with a patient's history may warrant genetic testing, but whether it is germline, meaning a patient's inherited it, or it is in the tumor, a BRCA mutation can open up opportunities for PARP inhibitors on a clinical trial. One other important area for molecular profiling that I like to point out with patients are Entrec fusions. Now, this is rare in melanoma. This may be 1 to 2% of patients, and that may be an overestimate. But Entrec fusions are noted in a number of different tumors, and there's 2 FDA-approved medications that have shown excellent responses and durable responses, meaning that if we identify one of these fusions, that patients with melanoma can take pills that are generally well tolerated, and patients can go on to have long-lasting responses. Now, Entrec Fusions are more commonly assessed on the most common molecular testing, but it is something worth asking your doctor to say, hey, has this been checked? Has this been covered? So I think the future is bright for cutaneous melanoma and even some of the other melanomas where we're better understanding the different drivers of melanoma and then trying to pair those specific mutations up, whether that is with standard of care with BRAF/MEK inhibition or with other clinical trials. And I think this is going to help us continue to better understand melanoma and what might be better treatment options moving forward. Some questions that I get from patients in clinic is, well, should I have this testing done on my tumor? Or I've heard about getting this testing done in the blood. At this point, we don't have enough information, but I always lean towards tissue testing first, if that tissue is available. If tissue is unavailable, there's been no tumor that's still available in a pathology lab, I think it can be helpful to do a liquid biopsy to be able to get that information, whether that's for just BRAF testing or more complete panel testing. If either has not been done, then that can be helpful to do a liquid biopsy or evaluating in the blood to see if you can identify any of those specific mutations. Sometimes it can also be helpful to consider repeating this testing if it's been a number of years. We do know that melanomas can evolve. Patients after receiving BRAF/MEK, the oral therapy, there's a number of different resistance mechanisms that can develop, and kind of reassessing to see has that melanoma changed. A lot of that is still under investigation and may not necessarily be approved by insurance. So that's still an area of research that we're continuing to watch and see, would that be helpful to do repeat testing? So overall, at this point, BRAF, checking the BRAF status for stage 3 is considered standard of care. In stage 4, BRAF testing is also considered standard of care, but full molecular profiling is very helpful to identify other targets that can be evaluated, whether that's on a clinical trial or patients can be treated with standard of care in stage 4. So a lot of excitement here, and I think more to come in the molecular profiling space.